Okay, good morning, everyone. Can everybody hear me okay? Give me a thumbs up. Okay, great, thank you. Good morning, everybody. Welcome to our online educational event brought to you by Parkinson's Community Los Angeles. Today, we're talking about treatments for Parkinson's disease and essential tremor, including deep brain stimulation. I'm Patrick Lasasso. I'm president of our PCLA nonprofit. For those of you who don't know, PCLA, we are a Los Angeles-based nonprofit serving the Parkinson's community. As you all know, because of the new world we're currently living in, we've had to adapt. So PCLA is now serving the Parkinson's community through virtual educational events like this one. I know we all wish we could gather together, but today we are together online, united in the fight to make our lives better. So let's put our hands together and give ourselves a virtual applause and welcome our speakers and celebrate together as a community. So before we dive in, let's quickly review a few rules. Please check that you're muted and stay muted. We've allocated time at the end for questions. You can submit them as we go into the Zoom chat function. Please keep your questions on the topics being presented today. Since timing may be difficult for some, if there's time, I will ask for spoken questions at the end. So we've got some great speakers today. Today, we're going to get some great information from neurologist Dr. Tyler C. Chung, who will discuss the typical symptoms and risks of movement disorders and therapies that are available to treatment to improve quality of life. We're also going to have neurosurgeon Dr. Igor Feynman, and he'll be discussing surgical treatments for Parkinson's, including deep brain stimulation. And neurology nurse practitioner Jennifer Birch will provide an overview of the surgery process, including patient follow-up and programming. We will also hear from a patient for their perspective on the surgery process and experience. I want to make sure we
know how to respond to that.
I think my computer just talked to me. I'm sorry about that. I want to make sure we have time for questions, so let's jump right in. Dr. Chung, thank you for joining us today.
All right, testing. You guys can all hear me? So I'm gonna share my screen here. Let's see if it works. Oops, sorry. Hang on. It's asking for privacy and all that stuff. Sorry, give me 1 second. It's just, I think it wants me to grant some privacy settings here. Okay, let's see. Oops. Is this working? No. Can you guys actually see my screen here? Because, good. Okay.
Yes, we can.
Okay. Sorry, I guess this is the first time I actually use Zoom on this computer, and it's asking me for like all the security features. Okay. Can everyone see the slides?
Looks good.
Okay. Okay. Well, thanks everybody for coming, and thanks for inviting us over. We are a group of neurologists and neurosurgeons and nurses and other practitioners who focus on movement disorders, and we're all on staff, and we're based around Huntington Hospital, which is in Pasadena, California. Many of us have affiliations with other institutions, haven't gone there for school, or having colleagues at other institutions as well. I'm part of a practice called Southern California Neurology Consultants, which is we're on staff at Huntington, and we collaborate very closely with Raymond Neurosurgery, who has a particular expertise in movement disorders. My contact info is below, and I think if PCLA is making the slides available, you should be there for your reference. Some acknowledgements. Thanks to PCLA for having us on this very sunny Saturday, and thanks to Jason and the Abbott folks for helping set this all up. All right, so this is meant to be a brief talk, and I'll try to keep it in time. And so this is going to be a very broad, top-level overview of some typical conditions that we treat. In particular, there's going to be a focus on some of the surgical therapies, and these are some common, probably the most common conditions that we treat with some of the devices that we use, as well as medicines, injections, and other forms of therapy. So primarily, we'll focus today on Parkinson's disease, this being the PCLA. I assume this is where many of you or most of you are interested in. Tremors and dystonia. Again, this is not meant to be a super comprehensive talk, just to keep everything within the time limits and just give everybody a very broad overview. Okay, so as many of you know, many of you probably know the basics, but I figure it's useful just to go over sort of just a general definition of Parkinson's disease. I consider it a hypokinetic movement disorder, meaning it's a condition that affects your brain's ability to generate movement and generally makes everybody move slower amongst other symptoms. Classically, it's described as a progressive slowing of your movement, shuffling of in terms of gait, freezing of gait, limb tone becomes more rigid, slowing of rapid fine motor movements, so like handwriting, utensils. There's a characteristic hand posture because the limbs are so stiff without treatment. Lack of arm swing. Often there's a resting tremor, not always, but very frequently. And just an emphasis on resting, which is a very distinguishing feature versus other tremors. There's potential cognitive symptoms, which are becoming more common than we previously thought. Memory, thinking, perception. We're increasingly recognizing this autonomic system involving gut motility, bowel movements, sleep patterns, blood pressure, and so on and so forth. And one distinguishing feature of Parkinson's versus some of these other conditions, it's what's known as a neurodegenerative disorder, meaning certain parts of the brain that are affected, primarily the part of the brain called the substantia nigra, which many of you may have heard of, experience some as yet unknown process which causes cell death, accumulation of this substance called alpha-synuclein into this clumps of schmutz, for lack of a better term, Levy bodies, which affect cell function. And this basically worsens year over year, and disease symptoms basically get more prominent and more progressive over time. Okay, so that's just a general definition of Parkinson's. Many of you I know may have friends or family, or yourselves are living with the condition, so you're probably very familiar with this. And there's probably a lot of some other features which are reported, but I figured in general these are sort of the broad definitions. And just briefly in terms of available treatments, I figured, well, in terms of just there are many treatments for Parkinson's, and in general, I think this is how I usually organize this in my brain. Let me see. So first of all, most of the treatments for Parkinson's are symptomatic. So these are medicines that directly address specific symptoms. Specifically, again, for Parkinson's, you have issues of rigidity, your fine motor movements are slow, your gait is shuffling, you have balance issues, some cognitive or mood symptoms. The symptomatic treatments are medications or therapies or injections that address these symptoms, but they don't necessarily cure the underlying condition. For example, like it's not like if you have like an infection, you get an antibiotic and the antibiotic kills all the bacteria and you're cured. These medicines for Parkinson's or therapies or surgeries don't necessarily cure or change the course of whatever is causing the damage to the brain cells, but they do address the symptoms and try to normalize your day-to-day life as best as we can. And then there's also disease-modifying therapies. Again, this is a new area in Parkinson's just because we've never ever actually had effective disease-modifying therapies before, but this is obviously an area of interest where could we discover some treatment that potentially could alter the long-term course and prognosis of Parkinson's. Okay, so going to symptomatic, most important, this is just a quick slide. Oftentimes, I think that we get carried, because we're physicians, we get carried away with the medicines and the surgeries and all that stuff. But it's important to remember, I think the most important therapy in Parkinson's is the physical motor training conditioning. And I assume many of you are probably involved in a lot of these community exercise programs. And I'm sure you probably have had talks with physical therapists and rehab doctors and gym programs in the area and dance programs, so on and so forth. The reason why this is particularly important, I mean, Parkinson's is a hypokinetic disorder, and so the treatment is you want to have more movement. In particular, the substantia nigra is part of the system of the brain called the basal ganglia, which is involved in motor learning and planning. And so if you're having problems with sort of learning or generating motor, you have to train the brain to be better able to compensate for the deficits because of due to the issues of the substantia nigra. There's an increasing body of papers and research that show that regular exercise or directed training improves quality of life and symptoms. And it depends on what people like. My general advice is to do something you like, otherwise you're probably not going to do it. Boxing programs are popular, a lot of weight-bearing exercises, cardio, cycling. I know there's a cycling program. There are a few of them in LA and in the Inland Empire. There's actually some papers on yoga and Tai Chi as well, which are coming out. But as long as you do it regularly, I think this is a very crucial part of Parkinson's therapy that shouldn't be ignored. Again, in certain situations, I guess people have severe gait issues that can limit the amount they can do, underlying spine orthopedic issues, folks with Parkinson's, variant of Parkinson's that have particular cognitive symptoms. But just to quickly go through this, it's whatever you're able to do is very important. And my joke that I often make is all these medicines and surgeries that we do, it's only worth doing them so that they enable you to exercise. And maybe that's kind of oversimplifying, but it's kind of trying to get the point across again. All right, so after I guess 60 years after it's been discovered, the mainstay of medical therapy, pharmaceutical therapy for Parkinson's is still levodopa. Before levodopa, I think the treatment options were much more limited. But essentially, this is a precursor to dopamine that your body turns into dopamine, and dopamine is a neurotransmitter that enables one brain cell to talk to another. Why is this important? Because the substantia nigra that we mentioned, as well as maybe certain other areas of the brain that are affected by Parkinson's, use dopamine to communicate to other cells in the brain. And so if you can imagine, if you lose substantia nigra, you're not generating as much dopamine in that one area, and that one connection loses the information and the communications between those parts of the brain. And therefore, the computation of the brain's ability to compute and generate movement slows down. So levodopa is a way to replenish the dopamine connection in these areas and enable that computation of movement and certain decision-making abilities and learning abilities in Parkinson's or in Parkinson's patients will be affected. So levodopa is a way to try and restore all of that. In general, the main thing to think about levodopa, the main thing to look for is you want to see an improvement of the rigidity, the fine motor slowing, the gait speed, sort of the motor symptoms. Some patients will report a cognitive or mood improvement, although that's not necessarily consistent. So when we're dosing these medicines, I think the main measurement of how well it's working is how well the motor symptoms improve. And then obviously you want to observe for any sort of cognitive benefits or side effects. It may also reduce tremors. That's the most visible, often that's the most visible sign of Parkinson's. It doesn't always improve tremors, but often people see a significant reduction. The most important thing is it's symptomatic, so it doesn't heal the brain. It kind of patches over the problems caused by Parkinson's, but it doesn't cure whatever biological process that is affecting those brain cells. All right, long-term problems with levodopa. So like I said, it's not curative. Parkinson's does get worse over years. As it progresses to later stages, usually about 5+ years, everybody's a little different. Some people progress very slowly, other people progress a little bit quicker. The affected areas continue to lose brain cells. And the levodopa usually it doesn't stop working, but it'll become more erratic. So it will still help the motor symptoms, but then the effects become less predictable. So for example, it's slower to kick in. Sometimes people, when in the beginning, it kicks in very quickly you take the medicine 5 or 10 minutes, 10 to 15 minutes later, it's working, people are moving around, they're having less problems. After several years, sometimes it takes longer, half an hour, 45 minutes, even as much as an hour, and people are waiting for the medicine to kick in. The duration effect is shorter, and instead of lasting for 6 to 8 hours, the medicine wears off in 2 to 3 hours. Sometimes it's unpredictable, so folks have a harder time dosing the medicines. Potential side effects due to higher dose requirements. In order to move, you have to take higher medicines, but then you can have issues with hallucinations, low blood pressure. Some people become more sensitive to it, and you get the involuntary movements. So you've seen Parkinson's patients on TV, you get the dyskinesias where people are kind of moving uncontrollably. There is a very long laundry list of helper medicines that are available to help lengthen the effective levodopa. These are limited and they're not perfect. But essentially, when you think about Parkinson's therapy nowadays, it's dosing levodopa, and then as the levodopa becomes more erratic, what other things can we add to sort of lengthen and regularize the levodopa? Just quickly, in disease-modifying therapy, this is an area of interest because everybody wants to be cured of Parkinson's, but for the past century, nobody's really convincingly found a way to do it. So to this date, there's no approved therapy that's disease-modifying for Parkinson's. There's a lot of candidates, but nothing for sure as of yet. I usually like to think of this in several, maybe three main categories. So one is the preservation strategy. So you're giving a substance or doing a surgery or some fancy treatment to preserve the cells that you have. You want to make them more healthy. You want to slow down the rate of cell death. You want to keep what you have. I think this is the one where there's a class of medicines that are probably the closest to potentially getting an indication for Parkinson's, primarily because they've already been studied for diabetes and they're already approved. We know they're relatively safe. So a lot of the work has already been done. These are what's known as glucagon-like peptide receptor agonists. So these are diabetes medicines. They're originally developed to help preserve the health of the cells in the pancreas, which is the organ affected by diabetes. But then they found that it actually may have a protective effect on some of the helper cells in the brain, like the glial cells, which help nourish and protect the brain cells themselves, the neurons themselves. So just briefly, there's actually been some small to medium-sized randomized controlled trials showing that folks who are on these medicines, in addition to levodopa, seem to decline more slowly than folks who are just on levodopa by themselves. So that hopefully should have some more news coming out in the coming few years. Gene therapy is a little bit more pie in the sky. There's been some efforts to deliver basically genetic payloads to affected cells in the brain. And I think the focus of, you could use this pretty much anywhere, assuming the technology gets mature enough. But the primary effect has been to boost the health of these glial cells to help protect the brain cells. There's been a few trials over the past 10, 15 years. I think where this stands is they've proven they can do it. It's relatively safe. It doesn't cause, the main side effect is causing cancer, essentially. It doesn't seem to do that according to the technology that they have, but it doesn't seem to really improve the Parkinson's as of yet. So that's still an ongoing story. There's the cleaning strategy, and I know there's been a question for mannitol, which maybe falls in this category. So these are methods such as vaccines or antibodies. The intention is to try and clean the schmutz found in the Parkinson's brain. So in the Parkinson's brain, for example, if you were to do a biopsy, or hypothetically, nobody really wants to do a biopsy, but hypothetically, if you were to do one, or if you do an autopsy, if somebody passes away, you see clumps of the schmutz called Levy bodies, which is made of these abnormal form of a molecule called alpha-synuclein. Alpha-synuclein probably in a normal stage probably does something important, but the abnormal form clumps together and is thought to cause the cellular dysfunction, which affects the health of the cells. So a lot of these, and this is also a kind of a intellectual idea that's being explored in other conditions such as Alzheimer's or PSP, where you try to get rid of the schmutz and maybe that'll help arrest or stabilize the Parkinson's so people don't get worse. Again, this for Parkinson's, this is in very early stages. I know there's one candidate that's a vaccine that mimics the alpha-synuclein and tries to trigger the immune system. There are other folks who they're working on what are called monoclonal antibodies, but as far as you know, these are all still in the safety and efficacy phase. So phase 1, I think a few are moving to phase 2. The tempered enthusiasm, all the trials that were done in PSP or in Alzheimer's for these categories of medicine did not work. So those trials failed. So this remains to be seen how well this is going to work. And then regenerative, I just threw this in here. So cell regenerative to try to regrow the brain cells. Now this is probably the most most of the long shot, just because we found it's very hard to regrow the brain cells and connect the brain cells to the right spots. So everybody always asks about stem cells. Stem cells are very prevalent in the popular culture and in science fiction. There were two main stem cell studies that were done, I think, in the 2000s to around 2009 or 2010. They proved they could do it. They proved that it was relatively safe. Relatively, there were some complications for the stem cells, but overall, it did not seem to really help the Parkinson's. And the problem is with the stem cells is it's extremely hard to get those trials up and running due to some safety and regulatory concerns. So I know there's some efforts to get subsequent trials going, but that's still kind of very much in its infancy. Interestingly enough, there's a lot of science that came out of those trials because you were able to observe healthy cells in the brain, healthy cells implanted into Parkinson's brain, and scientists were able to observe what happened to those cells. And those cells actually eventually ended up developing Lewy bodies. So the answer may not be just replacing cells, but they may have to correct some kind of condition in the brain that causes the Lewy bodies to form and causes the cells to become unhealthy. How am I doing on time anyway?
How much more time do you have, Dr. Chen?
Well, I think I'll probably just do I'll just go quickly through the other slides and I'll pass it on to Dr. Feynman. So anyway, so that's Parkinson's. Tremors, I'll just quickly mention this. Rhythmic involuntary shaking of the limbs typically arises from the brain of areas of the brain having difficulty with cerebellum. The most common example is the central tremor, and Dr. Feynman and Jennifer Birch will show you a patient of this a little bit later. Usually hereditary, usually as opposed to Parkinson's is a tremor that's very intentional versus resting. So even though it's not a neurodegenerative disorder, you don't have all the cognitive or gait issues and all this stuff later on in life, but it can be very disabling because whenever you try to do something, your hands shake a lot. There can be other conditions such as stroke, MS, medication side effects, intoxicants. And therapies, again, there's no curative therapy. Most of the medicines involved or medicines meant to dampen the tremor, but it doesn't cure the tremor. So people typically live with this their entire life. And as they get older and they have other medical conditions, the tremors could become more prominent. Medications, beta blockers are used to blunt the adrenaline-like substances in the brain, and that's usually the main thing that we use. Seizure medicines have been used. I've been less excited about these because of sedation and memory side effects. Again, so there's a lot of times people, the medicines either won't work or folks will have a lot of side effects where they can't tolerate the medicine. So that's tremor. Dystonia briefly is the disorder of the brain's ability to contract and co-contract the muscles correctly. And so what ends up happening, you have sort of these twisted postures. This can happen as part of Parkinson's, or it can be like a de novo, its own condition. So muscle spasms, which looks really bad. Oftentimes, the patient actually doesn't feel a lot of pain, but it looks really disabling. Many causes, genetics are often, I guess, a lot of it's a rare condition, but it's probably the most cited condition for doing some of these therapies. Strokes or other illnesses, or medications. So that's dystonia. Again, no curative medicines. Oftentimes, the primary oral medicines don't really work, and that is also true for Parkinson's. Sometimes they will work, but oftentimes because they're muscle relaxers, they'll have a lot of side effects. If it's just one muscle, like just in the hand, sometimes you could do Botox injections, which are convenient because you don't have to take oral medicines and they work for that one muscle. But if it's like the entire part of the body, or like an arm and a leg, or a very complex dystonia, oftentimes that's not really quite as effective. So anyway, I guess I'm running short on time, so I will probably skip the rest of my slides and I'll pass it over to Dr. Feynman, who is my colleague from the stereotactical and functional neurosurgery. And I'll be available for questions later if necessary.
Thank you very much, Dr. Chen.
Sure.
We're going to spotlight Dr. Feynman.
Thanks very much, Tyler. And thanks everyone for taking the time this morning to join us. And thanks to everyone who helped organize this. Let me just get my screen up. Okay, can everybody hear me?
Yeah, sounds good. Sounds good.
And okay, and everybody can see my screen. Okay, great. Thanks again, everybody, for joining us this morning and taking the time out. What I'd like to do, I'm a neurosurgeon. I work with Tyler Chung and with Jennifer Birch. Our program at Huntington has been around for about 20 years now. In addition to general neurosurgery, we do surgery for movement disorders such as Parkinson's disease and essential tremor and dystonia. So what I'd like to do in this talk is basically go over the conditions, try to explain as much as we can when the appropriate time is to intervene surgically after Dr. Chung can no longer help very much with medications, although at every point in the treatment of the patient, the neurologist is intimately involved. So even if the surgery is performed, the medications continue. Surgery, particularly in Parkinson's disease, is not curative. Let me see. So these are the currently approved DBS targets. The Parkinson's disease target has been used for about 25 years or so. Subthalamic nucleus is a target, globus pallidus is a target, and the VAM nucleus less frequently used in Parkinson's disease. And I'll explain a little bit about how we select and decide which particular target would be best suited for a particular patient. Essential tremor, this is the thalamic target, is the first target actually and the first indication for deep brain stimulation. This has been around for over 30 years. And then dystonia, globus pallidus, is the target that we use. There are two other indications, OCD or obsessive compulsive disorder, where surgery can be performed under what's called an HDE or humanitarian device exemption. And there's also an indication for epilepsy. And for OCD, the anterior limb of the internal capsule is used and the anterior thalamus is used for epilepsy. The bottom two indications are much less frequently used in practice, simply because the efficacy and the results in those situations are not as clear cut and not as dramatic as they are in the top three indications. So this is our team at Huntington. Jennifer, as I mentioned, is a nurse practitioner. She does the programming, she prepares the patients, she's in the operating room testing the patients. Dr. Chung does the medical management. He actually also is in the operating room with us because we feel it's really important for the entire team to see how the patient responds initially in the operating room to the treatment so that the programming can then be optimized much more easily after the surgery. Dr. Leong is a neuropsychologist who assesses all the patients before surgery and sometimes after surgery. Dr. Taylor does the neurophysiology, meaning the recordings during the operating room, and I'll kind of go briefly through that in the talk. He also prepares all the patients before the surgery with the imaging. Imaging is a crucial part of getting the surgery right in deep brain stimulation. And then Farida Key is the operating room charge nurse, and it can't be overemphasized that this is a team approach, and if Farida doesn't get all the equipment right, then surgery is a no-go, and we can all just hang out in the operating room and not be able to help the patient. The surgical procedure takes approximately 4 hours. However, the surgical procedure is just the beginning. What then happens is optimization of the surgery and of the parameters of stimulation, And that Jennifer will work on for several weeks, and sometimes takes even longer than that, until the optimal effects are brought out and the side effects are eliminated to the best degree possible. So pre-surgical preparation involves the neuropsychological testing, UPDRS testing, and this is Unified Parkinson's Disease Rating Scale. This basically assesses the severity of disease and the motor functioning of the patient, and then we can compare the how the patient is doing before and after surgery. Medical clearance is important for each of the patients, because many patients tend to be elderly and do have comorbidities in terms of heart disease and other medical issues. And then preoperative MRI, as I mentioned, imaging is extremely important. So this is on the day of surgery. I'll quickly walk you through that. The patient is sedated. This is the anesthesiologist, and that's a medication called propofol. So the patient is basically under anesthesia. They don't remember the frame being placed. Then they go to a CAT scan, where a CAT scan is obtained. We then fuse the CAT scan, which is the top image, to the MRI, which Dr. Taylor has obtained previously on the day of surgery. And then this is the planning software that we use. And depending on a specific target, we either use the anatomy directly, or we use known coordinates to get us to where we want to be at surgery. With advent of better magnets and 3 Tesla MRIs, we're able to see the deep nuclei in the brain here much more easily. This is the globus pallidus, and we're able to target much more precisely using anatomical targeting. And then there is, finally, after we've done our targeting, we check it with an atlas. So this is a human atlas embedded in the software, which tells us and allows us to confirm that we are where we think we are, based on what the average human brain would, where the average human brain would place the particular target that we're going after. Finally, before we make any incisions, we verify and we make sure that all the system, this is our stereotactic system, is set up correctly by setting up what's called the phantom system. So these 2 systems on top and bottom are configured to the same coordinates. And if there's human error, which happens very infrequently, we would see it immediately and say, okay, something is off and we gotta recheck all our coordinates. So that helps avoid any errors. Once the surgery starts, we use microelectrode recordings, and this is an electrode that's passed down to the target in the brain. And as the electrode goes down the brain, there are different signals that we see, and depending on the frequency and the amplitude of the signals, these are specific characteristics of the structures that we're recording from the brain, and we're able to tell based on the length that we achieve a particular signal signature that we're traversing the nucleus or the structure that we're aiming for. In this case, it's the subthalamic nucleus. Finally, with the patient awake during surgery, we do testing after we place the actual stimulator in. And the idea here is, yeah, great, we've gotten all the recordings and we think we are in place, but really the proof is in the pudding, is the patient's rigidity or tremor or whatever else that we're trying to treat better with stimulation in that target, and that's what we test here. We also test for side effects to tell us what the therapeutic range is. In other words, how close are we to a structure that will produce side effects and make programming more difficult. And if side effects appear to be at a lower voltage than we'd like, we sometimes move the stimulator to get away from that structure to make the programming after the surgery easier. This is an atlas that tells us of different side effects depending on in which direction we might be slightly off of the ideal target. So we use this quite frequently. And then finally, at the end of the procedure, after this is the patient's scalp has now been closed, suture closed, the patient goes to sleep. For this portion of the procedure, the patient does not need to be awake because we're no longer testing. and we put the generator or the battery in under general anesthesia. Then after the surgery, we immediately obtain a CAT scan, and the idea here is we want to make sure that there's no complication of surgery, such as bleeding, but we also want to make sure that we are at the target where we thought we should be. So what we do is we take this is a scan done after the surgery, we fuse this scan to the MRI and the initial target that we were planning for, and we want to make sure that the two are exactly superimposed. And in this case, the blue and the red are superimposed, and we know that we are where we thought we were and where we should be. Then after that, the hard job begins, and then Jennifer begins the programming. She usually starts at a low voltage a day after the surgery, just as a preliminary programming. And then the patients come in a week after surgery, and then as needed after that to adjust the programming, and again to optimize the effects of the procedure and minimize any of the side effects. So that's in a nutshell what DBS surgery is. I'll go over a couple recent advances. Since I've been doing DBS at Huntington with this team for 20 years, and a lot of the procedures has remained the same, but there have been a couple advances over the past several years. So one advance that's happened, and two companies are producing these leads now, Abbott and Boston Scientific, and these are called directional leads. What this means is, in the past, there were 4 leads, and you could only turn on or off a combination of the leads to shape the current around the electrode. And again, the idea here is to stimulate the structure that you want and minimize stimulation to a structure you don't want to stimulate, because that'll produce a side effect. So what these directional leads do is, in addition to allowing for the 4 electrodes and to modulate that way, each of the electrode here in the middle is divided into 3. So you can selectively turn on only a portion of the electrodes and stimulate in one direction or the other. So for example, if the structure producing the side effect is in this direction, you would turn this side off and only turn the other side on. So that's helped, and we've particularly used these electrodes with essential tremor patients, as Jennifer will mention, because often if both sides of the brain are stimulated in the thalamus for essential tremor patients, patients can get side effects of dysarthria or difficulty speaking, and that can limit the therapy. So if you can stimulate and get the efficacy without the dysarthria or other side effects, that's obviously ideal. The other advance that's happened recently is the ability to record from the brain, and Medtronic, another company involved in DBS, has developed that. And the idea here is that you are able to record something called local field potentials. These are brain signals that give you a particular signature, and that signature is now being correlated to a particular clinical condition in Parkinson's disease. So for example, if the patient is dyskinetic and has abnormal movements, there'll be a particular local field potential signature to that. And then the programmer can look at the record and say, okay, the patient was in this condition. How do I change the programming to eliminate or improve the time that they're in some unwanted condition? So this is still in the early stages of clinical use, but the idea is, as we learn more, this may be helpful down the road. Patient selection for Parkinson's disease. So how do we know who's going to be a good candidate? Initial good response to levodopa or Sinemet is important. Progression of duration in the off periods being either rigidity, freezing, or tremor, where the patient is not getting the efficacy of the medication. And these start increasing as the disease progresses. And what you want to do is intervene while the patient is still quite functional. And so, for example, if they were able to play golf for 3 hours and now they can only play golf for half an hour, and despite all the optimal medical therapy, this may be a good time to start thinking about DBS. Worsening dyskinesias with required dose of levodopa or Sinemet. So if the dyskinesia really get to be really extreme, then the ability to give the patient the levodopa is limited and treatment is limited. So we have to do something in that situation as well. We want patients to have relatively good cognitive function, which is why we test. We do neuropsychological testing, and then support of family and caregiver is extremely important in the post-operative period, particularly because the patients need to go to appointments. The patients may occasionally have some mood fluctuations, particularly with subthalamic implants, and that's really important. But in general, the goal is to prolong whatever the patient's best on state is to as much of the day as possible. So I'll really quickly, there's not a whole lot of time, but I'll really quickly show you a couple of videos here. This is a patient with tremor dominant Parkinson's disease, and this is after the surgery with the patient having the stimulator on and off. So this is the patient has the stimulator on and then off, and then once we turn on the stimulator, this is what they look like. So the tremor just stops. And this patient has stimulators on both sides, bilateral subthalamic stimulators. There is a question as to, in Parkinson's disease, as to which target to use. The two targets we use primarily are the subthalamic nucleus and the globus pallidus. The VIM target is good for controlling tremor, but is not good for controlling rigidity and freezing. So the only time we've used this target would be in patients who have no rigidity and no freezing, and their disease has been going on for quite a bit, so we don't anticipate those symptoms to occur. And while both the subthalamic nucleus and the globus pallidus treat just about every motor symptom of Parkinson's disease in terms of rigidity and tremor, there are some slight advantages to each target. So for tremor, the subthalamic nucleus is a little better. For bradykinesia, both are about equal. Rigidity, both are about equal. For dystonia, subthalamic nucleus a little better. However, if somebody has cognitive issues or some mild dementia, then subthalamic nucleus is not great because it can exacerbate it. We go with globus pallidus. Same if they have speech difficulties. However, if somebody has medication side effects, we would choose the subthalamic nucleus because that allows us to decrease and drop the medications more than the globus pallidus would. Quickly about essential tremor. So selection for essential tremor. Tremor doesn't respond to medical therapy, and that is not unusual. Tremor is more difficult to treat often than other symptoms of Parkinson's disease with medications. But in essential tremor, the medications that are used are typically primidone and beta agonists, and primidone and beta blockers. And if those two medications don't help, often others won't. And if the tremor is affecting the patient's quality of life, meaning they can't feed themselves, they can't participate in activities they like, it's a good time to start thinking about treatment. Head and vocal tremor are usually best treated with stimulating both sides of the brain. And this is actually the patient whom we treated this week, that Jennifer will talk about a little bit later, had this particular condition. And in that patient, both sides of the brain needed to be treated to arrest the head tremor. And then finally, the patient has to be in an appropriate physiological age, meaning their chronological age is not as important, but they're being healthy enough to go through surgery, and general anesthesia is. And then as DBS treatment continues, unlike Parkinson's disease, essential tremor is not a progressive disease. So if tremor is controlled, the patients typically have a normal lifespan. There can be some decrease in efficacy over time, requiring some additional programming, but generally the stimulation works for years, and the patients go on to live a normal lifespan and better quality of life. Finally, dystonia, real quickly again. Dystonia is the third most common movement disorders in the U.S. after essential tremor and Parkinson's disease. The dystonia classifications are primary, secondary, and tardive. Primary dystonia is sort of genetically related and idiopathic, meaning no clear reason other than the genetic mutation when it exists. Secondary is caused by another condition, such as tumor, trauma, and so on. And it is the primary dystonia that responds best, and primary dystonia that we typically would consider for treatment with deep brain stimulation. So treatment options are systemic medications, Botox, baclofen, and deep brain stimulation. What you want to do with dystonia is intervene, and this is why sometimes DBS is used in children in dystonia, because you want to intervene before skeletal deformities develop, because after that it's much more difficult to undo. Awake surgery sometimes is not possible because of the extreme movements that some dystonic patients have, so they can't really be in a rigid frame and have these movements without hurting themselves. So a procedure can be done with recordings under general anesthesia. And so to finish off, I'll just show you a dystonia patient that we treated. So this is the patient before the surgery, and you'll see that she's quite thin here. And the reason she's quite thin is because she's doing this motion constantly all day. So she was on narcotics at this point, and she's using an incredible amount of energy because she just can't stop moving. And you can see how disabling this condition is. Medications really don't work. And this is the same patient after she's had globus pallidus implants on both sides. So she's obviously gained some weight, and she really looks normal. The satisfying thing about treating dystonia patients is that, again, this is not a progressive disease like Parkinson's disease is. So as long as we're continuing the stimulation, the patient goes on and leads a normal life, and it's not a progressive neurodegenerative condition. So at Huntington, we've done, this slide is a little bit old, so we've done more than 500 implants. The majority have been subthalamic and globus pallidus. We've done VIM implants for tremor patients, and we've done about 11 implants for dystonia patients. Safety, there are risks to DBS. Fortunately, complications are rare. We unfortunately lost one patient to suicide after surgery. There was one patient who had a hemorrhage, a stroke, which is the most important complication, with the most serious complication of deep brain stimulation, who went into a coma and did not recover. The other complications we had some transient effects, and the patients recovered and were fine. Infections, while not great and require another surgery, are fixable, and sometimes, rarely, we've had to reposition leads that we thought were not optimally placed after the surgery. Seizures, we've had 3 patients who've had seizures, and after that, we now use anti-epileptic medications for several days after surgery. And since we started doing that, we have not seen that particular problem. So with that, I'll finish up, and I'll pass it on to Jennifer, who'll talk about programming and her relationship with the patients, and how she basically walks patients through the process of optimizing and making sure that what we've done in the operating room has the best effects possible.
Okay, great. So we'll get this switched over to Jennifer. Point of business, we're scheduled to wrap here in about 7 minutes. So I don't know, Jennifer and Dr. Feynman, Dr. Chung, if you guys can stick around for a little bit after that. We do have some great questions from the community that I'd like to have them the option of addressing. So if you can stick around, that would be great for a little bit after. And thank you, Jennifer.
Thank you. And thank you, Dr. Feynman. All right, well, we're going to fly through these slides because we really only have a few more minutes, and I'm sure you're all eager to meet our patient and see what her experience has been like. But I did want to go over a little bit of what programming is involved. And so let's, so I'm going to, actually don't need to go through that. When should DBS programming commence? This is always a big question for folks. So it's really based on patient's tolerance. We do some early stimulation right after surgery. It's kind of satisfying to leave the hospital knowing something's going on. Certainly after we see you in the office, we will do a little bit more programming. Sometimes we are limited by some of the after effects of surgery, and we will delay programming then until you fully recovered. Stimulation can, we typically can get the job done in about 3 to 4 weeks, maybe a session a week, but sometimes it takes a little more or a little less. DBS programming is performed to maximize DBS efficiency. We'd like your battery life to be good and minimize side effects, but ultimately we want you to be happy with your symptom control. Optimal programming, as I said, takes several weeks to months, and many patients require concurrent medication adjustment. And so you'll either be working with myself or a neurologist or your neurologist or with our team, Dr. Chung, and Dr. Chung also does a lot of the programming as well. So sometimes I'll just start everything off and then Dr. Chung will take over. Just to kind of go over some basics about the device, you do have electrodes implanted in your brain. That's shown at figure 1. There are 4 electrodes that we can manipulate, and there's an extension, and that connects to a generator. And then each patient has its own personal programmer, and sometimes we will allow patients to do some programming themselves if they'd like. Most patients prefer to come in and have the clinicians work with them and do the programming live in the office. DBS programming has modifiable parameters. There's electrode configuration, as I alluded to. There are 4 contacts. There's amplitude. There's several manufacturers, and they some of them use volts, some of them use milliamps. We certainly know how to use both, and pulse width and rate or frequency. And let me show you a little bit about how all that works. So here you have the electrodes. You can see here you have your generator. That gives us a positive electrode and in a monopolar setting. So we can use just one electrode and the other electrodes will be off. If we're encountering side effects, we might choose to do kind of bipolar settings. And that is where you're actually having your positive electrode and your negative electrode within the array. Which I just discussed, so we can pass on through that. This is an interesting slide. It kind of shows you the electrical field as we have selected the our positive and our negative. And in a monopolar setting, you're seeing this very round, beautiful electrical impulse that's within the structure and giving positive benefits. You can see in a bipolar situation, we're having side effect issues. We need to kind of narrow our field. We can narrow the field this way by just having your positive and your negative electrodes as seen here, and then get even fancier with multipolar configurations. Dr. Feynman briefly alluded to the directional lead, and this really is a nice picture that depicts the red areas of stimulation and how we can cut off various segments to avoid side effects. And this is most helpful in patients with VIM implants, but certainly can be helpful with any of the other targets. This basically shows you amplitude, and what amplitude or voltage or milliamps is just basically the intensity of stimulation. This is one of the parameters. Pulse width shows us the duration that you're receiving the impulse, and the rate is the number of impulses per second. Here's kind of some average settings that you see in the various targets, globus pallidus, STN, and VIM. DBS programming, when you're doing the initial settings, we're going to check impedances at each electrode. We're going to adjust amplitude, usually initially first. The lowest amplitude where there's maximal clinical benefit is what's most important to us. Clinical benefit of monopolar stimulation, or consider bipolar stimulation if there is side effect. We increase pulse width as well, hand in hand, as well as increasing the rate. That's usually the last parameter that I would touch upon as I'm programming. Placement issues can occur, but a lot of this can be worked out with programming. And I know Dr. Feynman touched on this briefly, but I just kind of wanted to go through the structures individually really quickly. So common placement issues with STN, patients can have paresthesias, abnormal sensations, kind of a tingling sensation. Those sensations usually are transient. Tonic muscular contraction, something we don't like to see, but can be programmed around. And again, these are just placement issues. Double vision, usually this is caught intraoperatively and adjusted for. And emotionality also, it can take some time to work through that. With the globus pallidus, we worry about internal capsule stimulation. You will get unusual muscular contractions, sometimes in the face, and those can be resolved with some of those programming settings that we have at our disposal. And stimulation of the optic tracts, you can get visual disturbances. And again, usually that's caught intraoperatively. And the ventral intermediate nucleus of the thalamus, you can also have stimulation of the internal capsule with difficulty speaking. One common thing that we see is paresthesias or abnormal sensations. Usually the brain tunes it out over time. Something that we find usually that maybe the target is a little bit deep, but we can program around this. You might see some gait ataxia. So I'm going to skip through this and go ahead and find our patient, Susan. I just kind of want to give you a brief summary of her. She has 40 years history of progressive bilateral upper extremity tremor and head tremor. And she just underwent bilateral VIM DBS placement with us. These are her current settings on the right side. This is her pre-op just this past surgery, Thursday. We did her second side. And so we wanted to show you her tremor because she doesn't have tremor anymore. Now she has both sides in. So I'm going to start with the video and then hopefully we can connect with Susan.
All right.
So that is her tremor.
Yeah. See that little tremor? We're going to take care of that.
Yeah, it will go away.
Yay. Okay, go ahead and put that side down. And let's see the other side, the treated side.
The treated side.
Woo-hoo. Look at that. Steady as a rock. All right.
Susan, if you're there, go ahead and unmute yourself.
Hi.
Yay, Susan.
Hi. It's been like night and day. My left side was worse than my right side, so they did the left side first. And I used to shake like outrageously crazy on the left side, and the right side was pretty well the same. They did the surgery, and now I'm just like, I can hold something without shaking. It's been great. I would do it again in a heartbeat.
Thanks, Susan.
All right.
I just want to touch on a few things. Really key not to let your batteries run down. It's a simple 15-minute procedure to replace. You know, the new devices now are telling everybody when they need to have their devices replaced. So there's some personal responsibility. It used to be you had to come in and talk to us first. Other big thing to watch for is skin breakdown, just to make sure that all your sites are good. When you go to the barber, that everybody watches where you've had your implants. Well, let's see. I think Dr. Feynman touched on some of this. So briefly, there's some, stimulation things that we can do to improve side effects and to help with patients' quality of life. And Dr. Feynman talked about the Medtronic Percept neurostimulator with the sensing technology. So there's a lot of neat things to help us really get the best benefit of these devices. I know this was a question from one of the patients. I think it's a great slide. It just helps reminds us about DBS and Parkinson's disease. So DBS is not a cure. Bilateral DBS is often required to improve gait, smooth on and off fluctuations, improve tremor, rigidity, bradykinesia, dyskinesia, never improve symptoms that are unresponsive to carbidopa. Programming and medication adjustment are required, and decrease medication in many, but rarely zero. I just want to say a special thanks to Jason, our Abbott representative, for putting this on, as well as PCLA and Patrick Lasasso. Thank you so much.
Well, thank you. Thank you, everyone, for an amazing presentation here. So we're going to hang out. I know you guys, I want to make sure we honor some of these questions here. So what I thought I would do is I'll ask a question, and then Dr. Feynman, Dr. Chang, and Jennifer, you guys can, I'm pretty sure on the fly, figure out who should answer that question. So take yourself off mute and sort it out. So some great questions from our community. I'm going to ask the ones that are really pretty much on target here in terms of the presentation. I'll start with Robert's question. I read an article suggesting using DBS very early in the diagnosis. I think what he's saying, is there an advantage to using it early in the diagnosis?
I guess I'll take that one. So there, the idea of using DBS early in the diagnosis, and this is kind of goes back to what Dr. Chung was saying. Exercise and the ability to participate in daily activities is very important in Parkinson's patients. So while you don't need to do DBS the minute you're diagnosed with Parkinson's disease, because it has not been shown to be neuroprotective. There have been some studies done, there's been some discussion, but that has not, at least as of now, been proven to be the case. On the other hand, you want to do it as early as is necessary before you start slipping and not being able to be as active as you were. So if whatever it is, the physical activity, I mentioned golf before, but it could be basketball or whatever else the patient does, if they are starting to not be able to do that with whatever the medical therapy is, that's the time to start thinking about DBS.
Great. Is there a good treatment specifically for freezing? I guess maybe does DBS help with freezing?
DBS,
Yeah. Oh, go ahead. Sorry.
go ahead, Tyler.
So freezing, the answer is it depends. In the early stages, levodopa and consequently DBS will help with medication response to freezing. The problem is, I guess, as disease progresses, sometimes, not always, but sometimes the freezing does not respond to treatment. So I would say the most powerful treatment for freezing is the primary treatment. So levodopa and deep brain stimulation, just because the deep brain stimulation effects mirror the levodopa effects. For unresponsive treatment, freezing unresponsive to those, a few things have been tried, but they're not dramatic. So medications, people have tried certain stimulants that promote norepinephrine. So there's this new medicine that was used for orthostatic for low blood pressure called Northera. And there's been some small trials showing that helps with freezing. We've actually had that work on one patient, but the problem is it's very expensive and it's hard to get prescribed. And there's been small scale studies with stimulants like Ritalin, but again, that's not very consistent. I would say if levodopa or DBS doesn't help with freezing, the next best treatment really is physical training. So there are specialized physical therapies that try and train the brain to overcome freezing. It really is a cognitive symptom. So it's what they call, I would say it's what they call, in the neurological world, you call that praxia. So kind of like the program to take a step is like stuck in this one step. In our experience, I think if the DBS and the medications, usually it'll, I would say maybe like 3 out of 4 cases, the medicine and DBS treatments, once optimized, will address a lot of freezing. There are a lot of folks where these treatments don't address the freezing, in which case, then I would pretty much try to get the patient on a very aggressive physical therapy, or sometimes because physical therapy is limited by insurance, then you have to go into one of these community exercise programs that focus on gait freezing and how to train your brain to overcome that.
But in most cases, DBS does help freezing.
Yeah, I think the vast majority of cases, people will see an improvement. So yeah.
Great. I have a quick sort of off topic, but it's a DBS related question. Is DBS patient good for a patient with Huntington disease? I guess that's Huntington chorea.
In general, no. I mean, people have sometimes done it on a palliative sense, but the problem with Huntington's, well, the movements are a problem, but the problem with Huntington's is the cognitive piece, which the DBS won't fix. So like the memory issues and the depression and all that stuff. I know some people have done it to try to control the movements, and yeah, that'll work for a bit. But then the problem is the other symptoms come to the fore, where the memory issues become very severe, and the depression and all stuff. I don't know. I mean, I don't know if you guys have ever done a Huntington's case or anything, but I mean, I guess so in general for Huntington's, I would say, I know there's a question on treatment modalities for Huntington's. It's still very, very limited, unfortunately. There are medicines that address the involuntary movements. I mean, I've seen papers where people publish like a case report on like 1 or 2 patients that they've just tried it because there's nothing else left. But my understanding is it's considered highly, like for what you get out of it, it's potentially a risk.
Okay. Is it true that after DBS, the patient would still need to be on medication? Also, there's no guarantee that it's effective for everyone, correct? It's from Steve.
So yes, most patients do remain on medications after DBS. With the subthalamic target, the drop in medications that we're able to achieve is usually more than with the globus pallidus stimulation. In terms of guarantee, I'm not sure what the guarantee question was about. Is that a guarantee of?
Yeah.
I think the question, I think they were referring to is it possible that somebody gets the DBS installed and it's not appropriate for them? Is there a guarantee that it would make some improvement? I think is the gist of the question.
So in the patients that we've treated, there has been a varying degree of improvement. For some patients, it's been completely life-changing. For others, it's been an incremental improvement. But I can't think of patients for whom there has been no benefit of the patients that we've chosen. Now there are a couple patients in whom we've had to move the electrode to optimize the positioning and then capture the benefit. But ultimately, if there's an experienced team as far as the neurologist and the neurosurgeon and the entire team who understands what the indications are, and those really should be the only people putting in DBS, then the chances of not getting any benefits are pretty small.
Right.
Okay. Go ahead, Dr. Chung.
Oh no, I was gonna say it's I guess more to just be very clear about what you're doing a DBS for. So, for example, if there's an issue of like hallucinations or memory issues or like unstable blood pressure, I mean, these are all Parkinson's symptoms, but these are known not to respond to DBS. Versus if it's clearly like a motor issue, like the rigidity or the freezing, then yeah, I would agree. I mean, there's some people who respond beautifully, other people maybe partially, but I mean, it's very rare that there's people that have absolutely no response.
Okay, great. I think I'm going to have to make this our last question. Do women present differently than men, and can muscle rigidity in the neck and shoulders be a presentation? I assume they're asking if that's something that DBS would help with.
Yeah, I guess I'll take that one. So gender, I would say in a broad stroke of things, the main difference is how what's the frequency. So population-wise, I would say women, male Parkinson's patients outnumber women. I think it's about 2 to 1. I think the numbers always continues being updated, but if I recall correctly, I think it's men tend to get it more frequently than women. Beyond that, I mean, there's the general symptoms overlap. So I don't think there's like a dramatic, like men get it in a dramatic one way and women get the other way. But I think looking through some of the papers, I think women, the earlier stages might be a little bit more mild, and after a while they kind of even out. There is some theory that like estrogens might be protective, but it's a very subtle effect, I think, if there is one. I think women might have more tremors, and there might have more of there's this particular phenomenon called REM sleep disorder where you have a very active dreams. There might be a slightly higher percentage of female patients that have those symptoms than the male. But in general, I don't think there's and I guess Dr. Simon and Jennifer, if you want to chime in, but I haven't really seen like a major dramatic like partitioning of symptoms.
Okay, great. Go ahead.
I agree with that. Yeah.
Okay, and I'm just going to toss this one last one out because we hear a lot, and we have you guys are awesome. It's been a great presentation. Since we have your experts here, why is fatigue such a problem? And you have any ideas on how to rectify that? Last question.
Okay. Well, fatigue, I think that's a good question because I don't think we really know. I'll offer some conjectures, and I think if and I'll let maybe if just because I think they tend to have the presentation initially in my office, and that's one of the things. And I think post-operatively, if you guys have noticed any particular reasons, I think it's a combination of many things. Fatigue, I think just people who have like a very untreated Parkinson's, I think it just takes more energy out of the body to overcome the movements. I think that's one issue, and I think the rigidity and a lot of these things really takes a lot out of the patient. I think another aspect is like the sleep architecture of a Parkinson's patient is disrupted, and this is actually an emerging area of interest in basic science Parkinson's, where people are realizing folks with Parkinson's often will have this abnormal REM sleep presentation where they're acting out their dreams, and the assumption is they're not getting enough like deep stage 4 sleep. And so it's kind of like your sleep is not as efficient, and the daytime there's a lot more sleepiness. sometimes the medicines, the levodopa, I think maybe 1 out of 4 patients will have a fatigue side effect from the levodopa. And I mean, it's not as bad as some of the older medicines, but I think it's there and it's very common. And a lot of people will say they'll take the medicines, they'll take a nap for like 3 minutes. So I think there's not like one particular feature. I think in DBS, a lot of times, so if you reduce the medicines, they have more on time. I think there's a lot more energy. Not always completely gone. So I know there's a lot of folks, even with DBS, will have to take a nap around 3, but I think a lot of people will feel that that's improved. I don't know if you guys have noticed that as well.
There's also one other thing in addition to what Dr. Chung has mentioned is mood can play a role into it. So
yeah,
there's definitely a comorbidity of depression with Parkinson's disease, which can present as lack of energy. We've sometimes seen in DBS patients, particularly with subthalamic nucleus, where there's some changes. Sometimes we see a positive change in mood after the surgery, where the patients just become extremely energetic as their mood is elevated, and that usually levels off over a few weeks. But that could be one other aspect of it.
Yeah, and I think it's probably inherent to the Parkinson's, because the depression in Parkinson's is different than like somebody without Parkinson's who has clinical depression. It's like Dr. Feynman said, it's a very apathetic type depression versus sort of the broader spectrum of depressive disorders.
Okay.
And,
well, thank you all so much, and thank you guys for your extra time sticking around. We really, really appreciate it. This was a wonderful presentation. So thank you for giving our community an opportunity to hear you guys. It always seems there's never enough time. We always never get to all the questions, but if you guys have questions, you can always email us at PCLA and we'll try to get them answered to you. We like to wish you all a very happy and safe Thanksgiving. And this presentation was brought to you by our nonprofit, Parkinson's Community Los Angeles. So we continue to serve our Los Angeles community and beyond because of the generous support you provide. If you enjoyed today's presentation, please consider making a donation so we can continue this important work. You can also just visit PCLA and click the donate button or email us with your questions or thoughts at info@pcla.org. Or you can email us also if you'd like to get involved and help us out here. You can find information on our upcoming educational events on our website, again, pcla.org, or you can always reach out to us at that email or by phone. I'll quickly go through our phone number here and I'll put it in the chat, 310-880-3143. And you'll reach our wonderful information and referral person, Sarah, and she'll take care of you. So thanks again, everyone.
Thank you.
Stay safe. Stay well. Happy Thanksgiving.
Happy Thanksgiving.
thanks for having us, and happy holidays.
Happy holidays.
Thanks, everyone.